To everyone who's joining us, welcome to our Seven Starling webinar series designed to give you as healthcare providers across specialties pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the lifespan of women's health. I'm Nazanin Homofar, as I mentioned earlier. I'm a practicing OB-GYN in Northern Virginia and the medical director at Seven Starling. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy loss and miscarriage, abortion, postpartum, and early parenthood. I mentioned this last time, but I did want to let all of you know today that we have expanded our payer coverage and accept Anthem, Cigna Evernorth, and Care First Blue Cross Blue Shield. I'm thrilled to be joined by Dr. Crystal Clark. I always look forward to our monthly webinars. I was just telling someone today that I think I've become such a better OB-GYN through this series. She is an associate professor of psychiatry and behavioral health sciences and an OB-GYN at Northwestern Feinberg School of Medicine, and has dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a researcher, educator, clinician, and thought leader. And we're also very lucky to have her as an advisor to Seven Starling. So welcome, Dr. Clark.
Thank you so much. It is a pleasure to be here. And yeah, I don't know about anyone tuning in from Chicago, but something is going on with our I don't know, our traffic. It's never been great, but it's on a whole new level of chaos these days.
Something happened to me last week that was very stressful, and I texted Carly and she said Mercury is in retrograde. I don't know what that means, but I think that I'll take it, because
yeah, absolutely. Strange times.
We are shifting gears a bit to focus this month. Previously, we've discussed perinatal and postpartum depression and anxiety, how to screen for it. And this month, we really wanted to shift the focus on mental health for patients experiencing miscarriage and for infertility. And some of you may know, October is Pregnancy and Infant Loss Awareness Month. For those of you who are OB-GYN providers, you'll already know this stat, but early pregnancy loss affects up to 25% of pregnancies. And there are many studies that have looked at prevalence rates of depression, anxiety, and even PTSD in patients. One study found that in the first week of miscarriage, level of anxiety was as high as 40% and 22% for depression. And that had decreased by the 12th week to 32% chance of anxiety. Another study found that 45% of women report symptoms of post-traumatic stress disorder 3 months after their miscarriage. And 30% of these women reported that the symptoms affected their professional life, and for about 40%, their relationships with family and friends. In the same vein, infertility affects about 10 to 15% of couples of reproductive age, and a number of studies have found that the incidence of depression and anxiety in infertile couples is significantly higher than those without infertility. So I know I've only touched on 2 or 3 studies, but Dr. Clark, can you tell us a little bit more about mental health conditions in these 2 populations that we should be aware of?
Yeah, so I think your overview of the studies is right on point, but it also underscores that we need so much more research in this area. There's not any large epidemiological studies or any kind of definitive stats like we do or have come closer to with like postpartum depression outside of this context. But what we do know is that anxiety, or what we see in clinical practice and what the articles that you just mentioned highlight, is how common trauma is after loss. And often the patients who are going through infertility treatments do experience loss at some point during that process. They're very fortunate if, just have one transfer or one IUI and everything goes well from there, and they have a healthy child born from that process. But very often they're doing multiple trials and sometimes multiple miscarriages and even, in the worst case scenarios, carrying almost to term, having a stillborn or something. Similarly, with the patients who are, just going through infertility treatments and don't have a loss, there's a lot of anxiety, significant amount of anxiety. Again, because there's this like anticipation and trying to, just trying to get through the process and hoping and sometimes that hope doesn't manifest into or doesn't turn into what they're hoping for. So there's a lot of anxiety there.
And what do we know of any long-term implications, for example, in future pregnancy?
Yeah, so anytime a patient has a onset of anxiety or depression in the context of pregnancy, or even prior to pregnancy, there is a risk for it to recur in that next pregnancy. And we don't have any great data on, well, just how that varies in women who have experienced a loss or have gone through the infertility process. But I would wonder actually if it's any higher, because anecdotally in my patients, there's this markers that I lost, if someone lost a child at 16 weeks, lost a pregnancy at 16 weeks, and they're constantly thinking about, okay, I'm approaching that 16 weeks. Am I going to lose this pregnancy? And then, they get to that point and they cross that threshold and they're feeling some relief, but some actually they might feel a little relief, but they're still kind of anticipating the worst the entire time. So I've actually wondered if it's higher than we would see in someone who has never had anxiety or had anxiety with a prior pregnancy, but just generalized anxiety disorder or have a history of anxiety disorder.
I think that makes a lot of sense too. I mean, and again, anecdotally, find I couldn't find anything myself, but just thinking about my patient population, if someone has had a miscarriage and knowing that, even offering them an earlier visit so that,
Yes.
especially at the point of when they had the miscarriage, so that they could get that, reassurance, or patients of mine who've had IVF. And I think the thing about it is that we don't often explicitly ask
Yeah.
someone who's gone through an infertility journey or a journey of recurrent miscarriage. We don't ask them about their mental health. And so if they don't acknowledge it in their medical history, if they don't acknowledge it as by saying they're on medication or having therapy, and I would imagine a lot of them are underdiagnosed. We don't get an opportunity oftentimes to just to say, like, are you doing okay?
Yeah. And that's something that needs to change, right? I mean, I am, I was recently talking about this with colleagues, and I don't want to get, sidebars too much, but the shifts in medical practice towards this, the ongoing shifts in medical practice towards the more business model, not something that I think any of the medical providers are trying to shift towards, but as it shifts in hospitals and academic centers and other practices, there's less and less time, and there's you need to ask these questions. So I think we're all grappling with, or where do you fit this in? But it's such an important question. I think when as an OB, even going through the history, you're like, how many miscarriages, ever had any losses otherwise, infertility treatments, all of those things. And if there's any yeses, then there needs to be a follow-up question. How are you doing? Have you dealt with any, depression as a result of that? Have you been experiencing? And then there should be like a little, a couple of questions on trauma. Because a lot of times people don't even realize they've been experiencing these things because no one's asked them the question. And it's hard to just say, are you experiencing trauma? Because a lot of times people are like, oh, I mean, I don't think so. I don't know. What does that mean?
Yeah. And we've spoken extensively about the use of various screening tools, including the PHQ-9, EPDS, GAD-7, for specifically perinatal and postpartum population. Knowing what we know, knowing what we were just talking about, how do you suggest we screen for mental health conditions in our patients that have experienced miscarriage or infertility? And
go ahead.
Or, well, can we use the same screens, or should we screen differently?
Yeah, well, I definitely think we should use the same screens because we don't really have any proof that anything better works at the moment. Again, another potential area of research. But yeah, I think if someone says I've had a miscarriage, or a stillborn, or anything like that, and I think it's definitely worth screening them for postpartum depression, anxiety, or not even postpartum depression, just perinatal related depressive
Mhm.
symptoms or anxiety. Even for using the MDQ for bipolar disorder, because in that type of stress and that hormonal, all of the hormones that they're experiencing, whether it's endogenous or exogenous, it has the potential to trigger all of these things, besides the stress of what they've gone through in general.
I
So
think, and I hearing you say this, I keep going back to the fact that we really need to do a better job of screening for all our pregnant patients because we
yeah,
don't know, we're not going to know people's history fully
yeah.
ever, right?
Yeah, exactly. And I also would just underscore, for miscarriage, for example, I think we aren't doing our patients justice in regards to miscarriage because so often it's like, oh well, they didn't have the baby, so they're not postpartum, but they actually are postpartum in their experience of their hormones going up and falling down. They just don't have a child to show for that, as do some women who've had a stillborn. They're still postpartum,
Right.
so they still have a risk for the onset of depression or anxiety, or other mental illnesses on top of the grief that they're experiencing, or even the trauma that they're experiencing.
I know it's not the focus of our webinar today, talking about intrauterine fetal demise or
Mhm.
stillborn, but any tips for um, what we should be offering specifically our patients that experience a stillborn? I know there's so much from the OB perspective. There's so much we have to cover when we have that unfortunate circumstance. We have to go through genetics, what people want to, um,
Yeah,
what they're thinking about in terms of disposal um, of the baby, religious
yeah,
services. Like, what do you think we should be offering those patients from a mental health?
yeah. It would be so awesome if they could talk to not only the chaplain but a therapist, on site, before they get hit with all of the, and let's see, it's all of the administrative
Mhm.
work that we have to do, in that context, and all the, more, yeah, just unrelated emotional questions that must be asked. So I really think it would be helpful, and to just give them a moment, and I honestly can't say I know what that looks like. I think, in an ideal world, that patient would be able to either address those things later, or have a day, or at least, some time to just process what happened to them before we go into the, series of other things that need to be addressed. Because I think, for at least I hear from the patients that it feels very cold and robotic, and like there's no empathy for what they've experienced.
I think I was looking it up. I think one country or a series of companies I started have started offering time off, or maybe it was New Zealand, time off for miscarriage.
Hmm.
And I've started incorporating it more into my practice as well because
Yeah,
I tell people you need some time. It's
yeah.
okay to take some time to process this. Too many times I've heard from my patients, they were in the middle of a meeting, they were doing something, they were working, or they were busy with their children, and they couldn't take the time to grieve the fact that they were actively going through a miscarriage. And I think as providers, making sure we are making our patients feel okay about taking some time and supporting them through that, uh,
Hmm.
we have to change the culture.
Absolutely. And I do think we can do that. I think if we're, like you're saying, that you've incorporated it into your practice, if the doctor is saying, hey, you need to take a couple of days, I think more and more patients will be like, oh, there's of course some going to be like, well, I got a big meeting tomorrow, or
Yeah.
whatever, that you might have to talk into it. But the more people buy into that, we start to change the culture, even if they need a letter for work or something like that that said, no, actually, this is what I'm prescribing you today. You need
Right.
to take another, a few days off, couple days off, and yeah, just do some self-care.
Absolutely. You had mentioned kind of asking about trauma,
Mhm.
finding ways to do that for patients, especially if they've had miscarriages. Can you model a few questions for us that you may ask during a visit to understand if a patient may benefit from a referral to behavioral health?
Yeah, so some of the just classic questions might be, do you have flashbacks of, you know, the, whatever the process is. I have people that have flashbacks from having postpartum depression. So it could, whatever their situation is, you can ask them if they're having any flashbacks. Is there anything they avoid? So often after a person has experienced trauma, say just for a classic example, they're robbed on a particular street by a certain building. They might avoid that street, driving down that street. They won't walk down that street. Similarly, something happened in the hospital. Now that every time they get on the elevator in the hospital, they have a panic attack. So ask about any things they avoid or that triggers significant anxiety that's related to that past event, and if they're having any, if they've had nightmares that are recurrent related to that event. So those are just kind of some three very classic questions.
I love that. I was writing them down. So, do you have any flashbacks from the process? Is there anything you've avoided since you've gone through the experience, or do you recognize any triggers? And have you had any nightmares that are recurrent?
Yeah.
That's really helpful. What I think you've touched on it a little bit, but what do you see as being the biggest need for mental health in these populations, and what are the best treatment options?
Yeah. So I think so. So two different answers in terms of going back to the infertility process in the patient population going through that. I really think a lot of practices I've already adopted, having psychologists in-house and who are seeing patients before, after, during the process. A lot of them also just have an optional situation. Some have groups, but I think there needs to be a shift in culture. I think there's still this feeling of, at least as patients again described to me, of like a factory line, a factory belt. And so, yes, it does help to have that mental health provider on site, but when the rest of the experience does not address the human experience of going through
Mhm.
this, it's really a little difficult. So I think again, people actually knowing there being enough time or to know the nurse that you're working with or the doctor, seeing the doctor more, or other people that are involved in becoming a more human, personal, individual experience. And I think there's got to be a way for us to make that happen in practice. Um, and in addition to that, having more available, I think groups for people and more I forgot what they call it, like peer support. So direct
Mhm.
one-on-one peer support.
Mm.
So maybe patients are signing up for that. There are definitely some online resources that I've given to my patients that are kind of like Seven Starling. Someone started, a online support where they link you to a peer uh, to work with you throughout your process. But imagine if clinics were doing that, where they were offering patients the opportunity to volunteer and
Yeah.
and referring to kind of broaden that reach in
I
terms
think
of
that's
go ahead.
powerful. Yeah, like we've seen that. I just think of especially patients of mine who have babies in the NICU, for
Mhm.
example. Like we
Mhm.
know that there are
Yes.
these support groups online for NICU parents, and they're very powerful. And like in the middle of the night when you're up,
Mhm.
um, thinking and worrying about something, you can log on, and there's someone else there that you can talk to. So.
Yeah. Yeah, I think and that's definitely a population that needs it as well, and NICU parents. So yeah, I definitely think more peer-to-peer support would be very helpful, and maybe more focus groups from the patients to figure out, okay, how can we improve this experience?
Mhm.
Everything may not be something that can be changed. But I'm sure there are some things that patients can give feedback about that we in the medical community can do better. In terms of loss, I really just think we need more support on sites at the time for those events. And then, and until we can, just having, definitely having support groups again that are accessible to the patients, as well as, an immediate referral. But
Mhm.
I think, as a provider, we have to be able to take that moment and just kind of, sit in that moment with them, like,
Right,
okay, before we start our administrative duties.
right. Silence is okay.
Yes,
Sitting with
silence is okay.
someone for a while is
Mhm.
okay. I think we've also seen that too for miscarriage management. Offering a patient a follow-up visit
Mhm.
can be beneficial just to give them some closure. Uh,
Yeah.
I tend to do it at 3 to 4 weeks just because I'm also assessing other things as well, like their bleeding. But I know that I've also seen models where people offer a follow up visit at 2 weeks
Yeah.
just to check in. But that's a great reminder of a time when potentially, even though we're blessing the person usually and saying, great, everything, the miscarriage, if you needed to manage it with medication or surgically, um,
Mhm.
it went well, but like, how is your mental health? And do you need some
Yeah.
additional resources? It's a good time to check in.
Absolutely. I think that's great because it also gives the patient time to process what has happened. They may have questions. And to your point, they really need that closure. And some of the questions they may have, they might just need reassurance that did something go wrong? There's
Yeah,
a lot of questions like that. I also think a phone call, a simple phone call could be such a powerful um, connection for the patient, just that, the doctor thought enough, cared enough. And it also leaves a very caring, uh, like just a caring touch
hmm,
for the patient. So because a lot of times they're feeling like, well, that was just another number. Nobody cared.
right,
Did I even get good care? They start to get paranoid, and maybe not in all cases, but in some cases, paranoid
yeah,
about whether it was even, warranted that this happened to them. And that phone call actually can make them feel like, okay, I am human.
right.
Someone does care. And it may dispel some of that paranoia as well.
I think that's a great idea. Yeah, that's a great idea. And if you work in a busy office and you're constantly trying to stay
Yeah,
up to date on your inbox and call patients too, I think it could be appropriate to have the medical assistant or the
absolutely.
LPN just call and check in and say, we know that postpartum it works really well at the 24 to 48-hour mark, but just saying,
Right.
hey, doctor, we wanted to check in from the office and see if there's anything we can do to support you. And if there's any medical questions, you can direct it to the
Yeah.
provider. But that's also another way to so that it doesn't have to feel like you're signing up to spend a lot
Hmm.
of everything.
Yes, absolutely. I agree. We gotta we clearly need more time in the day.
I know. Tell me about it. Do you have, Dr. Clark, do you have any online resources that you refer your patients or other providers to?
So there are lots of different online resources. I don't have a list in front of me, but I would let's plan to post that and put it in our newsletter and maybe post it online because there are several for even different groups. So some also geared to like African American women or other women of color. There's a
Mhm.
lot of different groups out there. So um, I would love to give a more comprehensive list.
That sounds great.
Yeah.
We can include it in our newsletter so that
Yeah.
our listeners can
Yeah.
can look at it. And I know we briefly touched on this, but just trying to crystallize it. If you could ask your OB/GYN or primary care colleagues to adopt one practice or change one behavior when it comes to addressing the mental health needs of patients who are experiencing miscarriage or infertility, what would it be?
Yeah, so I would definitely say let's change the culture on miscarriage. Ask about it, screen when someone has reports a history of it, meaning screen for depression or anxiety, and encourage them, if it happens during your care with them, then encourage them to take the time off. We've got to, change the culture of that being something where people suffer in silence and feel like, well, it doesn't mean anything to anybody else, so now I have to just kind of be quiet about it and be isolated and experience this alone.
I think I mean, if we could, I would love for us to to work towards that, and to everyone who's listening today too, if finding a way to incorporate it in your practice, no matter what you do, helping change that culture, I think will just also help our patients make them feel like they're seen and heard, and that
Mhm.
we do truly care about all of these aspects of their life. I think, Dr. Clark, I really appreciate all of this information today. I want to leave everyone with a quick recap, that ideally screening patients in the first trimester when you see them in pregnancy. If you're going to be seeing them in pregnancy, you can screen them with our traditional tools to see if they have any concern for mental health conditions, but specifically, even if you're just seeing your patients for infertility who have experienced infertility and miscarriage, if you're seeing them for another visit, just acknowledging what they went through and asking them, do you have any flashbacks from this process? Is there anything you've avoided since you've gone through these things? Are there any triggers? And have you had any nightmares that are recurrent, or easy ways to hopefully start the conversation? And that if we can all work on changing the culture, hopefully we ourselves and our patients will be better for it.
Yeah.
Thank you all. I know we ran over a little bit. I appreciate everyone's patience at the beginning, but we hope that you were able to get something from this 30-minute discussion. And also wanted to let you know that we have adapted our patient education and referral materials at 7 Sterling for infertility and miscarriage that have no pictures of babies. We realized that we needed to do better to make sure that our materials suited the needs of patients. So they were mailed to all of your referral partners. So ask your office manager or respond to the newsletter if you need some. You can also direct patients to 7sterling.com/consult and instantly book into our consult calendar, which is where the QR code on any of our materials leads to. We are committed at 7 Sterling to providing the full spectrum of women's mental health care and would love to support you and your patients. So please check out our website, 7sterling.com, to learn more. And then if I